This video is going to focus on acute renal failure or acute kidney injury or acute renal injury, however you want to call it. Definition is rapid onset within 1 to 3 days of azotemia, which is defined as increased serum BUN and creatinine with oliguria. This is what these three things constitute azotemia. And as you can see by my drawing here, which is I'm not an artist, but you can have pre-renal acute renal failure, intrarenal, and post-renal. Now, post-renal can back up and cause intrarenal, and pre-renal can cause intrarenal acute renal failure. But generally, intrarenal failure, intrarenal failure also rapid onset 1 to 3 days, unless you're simply dehydrated and can be fixed with drinking lots of water and fluids. It requires dialysis and or kidney transplant. So I'm only going to focus on the common ones, and because there are a lot of intrarenal causes of chronic kidney disease. Most develop slowly over time, such as that caused by diabetes. But in terms of acute renal failure, renal tubular necrosis, renal papillary necrosis, and acute interstitial nephritis. Kidney stones. Kidney stones cause acute renal failure, and they're typically not fatal without dialysis, I don't believe, but I would call them more subacute renal failure than acute, because it takes time to do nothing about it. Well, they're extremely painful. So, I mean, prolonged hydronephrosis is going to cause interstitial bleeding in the intrarenal, or it's going to cause dilation of the calyces and suppression of the medullary cortex, which is where all the nephrons are, the parenchyma, which control the blood pressure and excrete waste. So that's how the kidney stones can cause acute renal failure. Now, to diagnose an acute kidney stone, you can use a KUB X-ray. CT scan is gold standard because it can detect uric acid stone, which are radiolucent. The U is for uric acid because they don't show up on X-ray because they're radiolucent, but they're only 5% of all stones. And so you can miss a uric acid stone if you don't do MRI. Sorry, not CT, MRI. Okay, so let's so you have pre, post, and intrarenal. So first, let's discuss BUN and CA ratio. Normal is 8 to 20. We like to say 15. So basically, BUN and CR. So your amino acids, as you eat food, your proteins get broken down into amino acids eventually, and the amino acids gets cleaved by deamination and produce ammonia, which is toxic to the body, which is why the liver converts it to urea, and the other two carbon backbone go into the Krebs cycle to make ATP. That's why we have BUN and not ammonia in our blood. If we have ammonia in our blood, we go into metabolic alkalosis, which is common in kidney failure, because eventually in end-stage renal disease, your liver is not going to be able to, there's going to be more ammonia produced than it can transform, so you can get some ammonia buildup and metabolic alkalosis. The tubular disease, the only time that, so in acute renal failure, you always have a BUN to creatinine ratio over 15 because of reduced GFR. So I can explain it like this. The only time you have BUN creatinine less than 15 and fractional excretion of sodium less than 1% is in tubular disease, such as renal tubular necrosis, renal papillary necrosis, and acute interstitial necrosis. So here's the nephron, here's the glomeruli, and the nephron is lined by the epithelial cells, and so this would be called interstitial intrarenal acute renal failure. So what happens is that it can be ischemic or toxic. So ischemic, remember, ischemic is usually a result secondary to pre-renal acute renal failure, such as an embolus, vascular disease, sickle cell anemia, platelet disease, heart failure, reduced cardiac output, or vascular disease, or efferent arterial stenosis. So what happens is you get the pre-renal acute renal failure, and that causes decreased GFR because you got a stenotic afferent, and it's going to decrease glomerular filtration rate. So in acute tubular necrosis, what happens is if it's due to a toxin, such as the most common toxins for acute tubular necrosis include aminoglycosides, most common, lead and ethylene glycol, typically seen in children who eat paint chips containing lead or drink antifreeze ethylene glycol, which is apparently tasty, which I did not know that. So they may drink that. Myoglobinuria from crush injury to muscle, radiocontrast dye, and tumor lysis syndrome. And we prevent tumor lysis syndrome by prophylactic hydration and allopurinol, because what happens in when you do the chemotherapy, especially for leukemia lymphomas, where you have rapid cell turnover and you get urate-induced acute tubular necrosis. So the urate destroys these epithelial cells, and what happens is you get blockage of the tubules. So the only time that your BUN has a fractional excretion sodium over 2% and a BUN to creatinine ratio of less than or more than 15 is in tubular disease or late long-standing long-standing nephrolithiasis. All other acute kidney injuries is going to be the tubules are working, so the sodium is being reabsorbed, the BUN is being reabsorbed, and the creatinine is being secreted. This, I won't get into too much about this, but this is basically a normal kidney can have some cysts. This is a autosomal dominant, dominant polycystic kidney disease as in adults. So it's fluid-filled cysts. They develop, as bad as this looks, actually these patients don't go into end-stage kidney disease until they're like 65 or 80. Because dominant is acquired and recessive is genetic in children. Recessive is kids, because recessive is smaller, and dominant parents are dominant, so they get this. And here the only treatment is kidney allograft anastomosis to the external iliac artery and vein. And then the ureter gets anastomosed to the bladder. The diseased kidneys are left in place because for many reasons. Unless they're infected and the infection needs to be cleared up, aspirated, resected, abscessed, drained, what have you. Okay. This is children, so you can see this is post-mortem. You see all these tiny cysts, air cysts, and these kids, 1 in 3 die in the PICU. The ones that make it get end-stage kidney disease around 15, 20, treat it with lowering hypertension meds, ACE inhibitors or ARBs, not at the same time, beta blockers or diuretics. Phosphate, not potassium binders, but phosphate binders. If kidneys can't excrete the phosphate, that's a typo. EPO shots for anemia and hormone, human growth hormone for stimulation of body growth, because kidneys are responsible for stimulating blood production by EPO production. Don't give them NSAIDs, no contact sports. They're more prone to trauma injury leading to internal bleeding. But the point of this lecture is not things that cause end-stage kidney disease over long term. We're talking about 1 to 3 days. So we got urine sediment. Typically casts. So this is post-renal, aka secondary to nephrolithiasis for the non-urologist. Great. So we don't have to do a lot of thinking, and the patient can die. Calcium oxalate crystals are the most common and the most painful kidney stones encountered. They're radiopaque, as are all of them except for uric acid and cysteine stones are sometimes visible but still radiolucent because they are clear hexagonal. So the calcium oxalate stones basically can result from antifreeze, vitamin C abuse, common in hypocitruria. You treat with low sodium diet. Citrate binds the calcium and thiazide diuretics, and also drink lots of water to try and pass the stones, and pain management. And they look like little pyramids on, as you can see on the microscopic slide there. Uric acid crystals. There you see they're rhomboid. So uric acid, easy to remember because they're like rhomboid. Sturtevite crystals are coffin lid, and that's because they're ammonium magnesium phosphate stones, and they're they are very large, and they can completely block the calyces, and usually caused by urea's positive organisms, notably for the USMLE, Proteus, Staphylococcus, and Klebsiella. They hydrolyze urea to make ammonia. So you treat with, they cause staghorn calculi or deerhorn calculi. You alkalinize the urine, but generally you can't really use antibiotics because if once they show you a picture of the stone, you'll see why antibiotics can't really treat the underlying infection very well. So surgical removal of the stone is the treatment. And cysteine crystals are generally caused by hereditary autosomal recessive condition where you get cystinuria, transport defects in the tubules cause the Cola syndrome. You can't reabsorb orthodine, lysine, arginine, and since cysteine is poorly soluble, the stones form in the urine. And remember, for soluble, in order to excrete anything from the ureters, it has to be water soluble. Cysteine is poorly water soluble, so usually begins in childhood because it's hereditary autosomal recessive. They have 6 sides, and they should be treated with low sodium diet, alkalization of urine, chelating agents, because they can turn into staghorn calculi later down the line. So it's important to recognize this early. Otherwise, they'll go on to have a more serious problem with the staghorn calculi. Okay, so that's about that for those. Here's the gross images of some. These are stones that have been passed. You can see the uric acid stones have some spikes on them, might be painful. That's a bad calcium oxalate stone. Stereotype calcium phosphate doesn't look too painful. The pain depends on the morphology of the stone, the size of the stone, the caliber of the ureter. So you can just think of, you see this more accurate calcium oxalate gross morphology. It has spikes on it, and you can just imagine trying to pass that stone. It's one of the most painful conditions ever, is passing a calcium oxalate stone. Calcium phosphate also typically painful. Certified struvite stones, basically surgical removal. Now this cast, even though it says it's a red blood cell cast, I wouldn't put my life savings on it because I can't really see very good morphology of red blood cells there. So why are the muddy brown granule casts look red from acute tubular necrosis or any tubular disease? They're red. See the bottom left there. That's because they're stained with a special SM stain to elucidate the granular appearance of muddy brown casts. The hyaline stone, I believe it because it's difficult to visualize. It can be normal in athletes. The white blood cell cast, I believe it. Those look like white blood cell neutrophils there. Some sort of lymphoid cells. The epithelial cast, couldn't say for sure. Red blood cell cast, there you go. Even though it's brown, you can clearly see their red blood cells by their morphology, absence of nuclei, and donut shaped, and then you have mixed. As you can see, in A, you can't really see the acute tubular necrosis. That's why they're called brown muddy casts. But you do the SM stain to elucidate the granular appearance. This is the staghorn calculi, surgical removal of stone, if possible at all. Okay, so most other intrarenal causes that lead to end-stage kidney disease are more progressive in nature, so that don't require immediate treatment. Heart failure reduces cardiac output, which means basically, again, I can demonstrate this. So if you have your tubule here, your afferent, glomeruli, and efferent. So if you have low total intravascular volume, your body is going to try to preserve that volume, so you're going to have increased glomerular flow rate and a decreased GFR because the pressure is going to be pushing up, and in instances of acute tubular necrosis, that's how you get decreased GFR. But here, the decreased GFR is just going to be because it's going to go through the glomeruli and say, nope, we don't have enough total intravascular volume, so we're going to go up, and that's going to cause decreased GFR. Sickle cell anemia and platelet disease are a little more complex causes of prerenal azotemia. Essentially, the sickle-shaped in a sickle cell crisis, you can have damage to the efferent arteriole, leading to fibrosis or formation of inflammatory response, which is also why when you're on peritoneal dialysis for tubular damage, you add heparin to thin the blood to help slough those cells out to avoid fibrin primary hemostatic plugs from occurring. So that's a basic review of acute renal failure for the non-urologist. So basically, if a person is screaming their lungs out, it's calcium oxalate stone until proven otherwise. Hydrate. Alkalize the urine with bicarbonate. And let them pass the stone. If they can't pass it, pace the urologist for either the intraurethral endoscopic removal with stent dilation, because the stent will dilate the ureter and allow extraction of the stone or multiple stones. If you have renal papillary necrosis, also you get sloughing of the epithelial cells in the tubules, and it can lead to acute interstitial nephritis. The only I'm not going to get into nephrotic and nephritic syndromes, but rapidly progressive glomerulonephritis is in adults one that can cause acute renal failure requiring immediate treatment. Other glomerular diseases are generally more subacute to prolonged until they cause end-stage kidney disease. But we want to try and treat the disease before, so we can avoid peritoneal dialysis. I hope this was useful, and thank you very much for watching.